In 2020, CHRIAS went digital. Our providers delivered 46 weight loss webinars to nearly 500 registrants throughout the year. Throughout our weight loss webinar series, attendees will be given explicit information on the ins and outs of the bariatric journey. For starters, our speaker of the night would elaborate on the definition of obesity, its causes, and how to treat it. Furthermore, we take a look at who qualifies for bariatric surgery, the different types of the surgery, and how patients' overall standard of life increases. Overall, our top-notch providers deliver a thorough analysis of our bariatric program and expand on how we can increase the quality of life to our patients. In case you missed it, here's a quick look at what we had to offer throughout our weight loss webinar series.
Presentation tonight is really to introduce the St. Francis Bariatric Program, but also to talk about bariatric surgery. Now, myself, Dr. Gail Wynn, my associate, and also Dr. Michael Peters, Dr. Rahul Singh, Dr. George Ibrahim are the bariatric surgeons who perform bariatric surgery at St. Francis Hospital.
So obesity is a disorder that's caused by accumulation of excess body fat over a period of time.
Now, fat by itself is actually a very important component for our organism. In fact, without fat, we would not survive. In fact, the units that make up the tissues in our body, the cells, are actually covered by an envelope made up almost exclusively of fat molecules. So fat is absolutely essential to our survival. But when we start accumulating fat in excess of our needs in our body, then a disease state occurs, and that's exactly what obesity is.
What we usually use is something called body mass index. It's the ratio between weight and height. There is online formulas for that. They are available. There's apps you can download on your iPhone or Android that are free. And all you need to do is just put your weight and height, then the number comes up, which is the body mass index. And normally this number should fall somewhere between 20 to 25 or 19 to 24. This is the normal body mass index. Above that, we call that overweight. Once it hit 30, that's obesity. And once it hit 40 or above, that's what we call severe obesity.
Causes of obesity are what we call multifactorial. That just means many individual things contribute to the disease of obesity. And these include everything from our genetic makeup as humans. Obviously, our genetic makeup is relative to mothers and fathers who may have weight problems. Our own metabolism, which can be affected by our society as well as our food we eat. Our behavior certainly plays into that. Our behavior has changed as humans, as we've evolved over the last 100 years. Our environment has certainly changed over the last 50 to 100 years. And socioeconomic status and culture certainly play into obesity and define what foods we eat and why we eat certain foods.
In the last 50 or 60 years, the number of obese individuals has tripled. So what changed in the last 50 or 60 years? Pretty much is the way we live. 60 or 70 years ago, they didn't have all that fast food restaurants around us. We didn't have all these ready-made dinners. You just put in a microwave and 5 minutes, your dinner is ready. So food has changed. Also the way we work. I mean, now we have pretty much computers and machines. We don't really exert ourselves much. We have cars, we have elevators, we have gadgets. If you look to your coffee table, you might have 2 or 3 or 4 remote controls. So pretty much life has changed. And because of that technology and the way we live our lives, we're paying the price by being more and more obese.
What are the health consequences of obesity? This slide actually is a slide that is here to show us the benefits of weight loss surgery, the number of medical conditions that are improved after weight loss surgery. But another way to look at this is really to see how many medical and health conditions can occur when we have obesity. And we can think of many things like sleep apnea, for instance, heart disease, high blood pressure, heartburn or reflux, inability to control one's urine with stress urinary incontinence, joint problems, leading to orthopedic issues?
Starting from the brain, there is a disease called Pseudotumor Cerebri, where the pressure within the brain, within the fluid that is within the brain, it kind of goes up and starts to cause damage to the brain tissue itself, and it leads to patients having chronic headaches, changes in the vision, which over time become permanent, and other very serious downstream effects of this disorder. And the treatment of that, well, the first treatment of that is actually treatment of obesity, help the patients lose weight, and a lot of times this medical problem just goes away.
Think of it like this way. If you have a machine or a car, let's say for example, and you are driving 2 million miles a day, how many years this car will last you, or how long the machine will last? If you are overusing it, you're going to break down soon. Same thing happens with your body. When you have this uncontrolled obesity issue or too much weight, your heart has to work hard, your lung has to work hard, your joints carrying more weight have to work hard. So, one day, my blood pressure is up. Now I need to be on medication. Oh, I had blood work for routine exam and turned out I have diabetes. I have high cholesterol. These three will lead to coronary artery disease, heart attacks, strokes.
Now, the treatments for obesity are multiple and many. It's a several billion-dollar industry. But really, it should begin with lifestyle modification. Because even after surgery, if lifestyle modification is not maintained, the weight will come back, all right? So lifestyle modification is key, and this means that we should shop differently. We should educate ourselves about what is food, what is edible, why we crave what we crave, and we need to be much wiser consumers. So with increased physical activity and a more educated patient, we can move on to surgery and get through that safely and have a good outcome. We do have drug therapy for some of our patients who are not of the appropriate body mass index for surgical intervention. And we even offer that to some patients who are maybe 5 or 6 years out from their bariatric surgery and they find they need a little help. Surgery is saved for the National Institutes of Health indications for operative intervention, which means we don't operate until somebody has achieved a body mass index of 35 or higher. This is when the benefit of the operation outweighs any risk of anesthesia, the surgery itself, and when we're expected to see a significant reduction in those other comorbid conditions rapidly after a surgical intervention.
Now, why is it that diet and exercise by themselves are not enough? Well, people who struggle with obesity most of their life know this very well because they have been through it. But the truth is that when you do diet and exercise to try to come down from a weight which is about 100 pounds or more, above one's ideal body weight, then the diet and exercise fail. Maybe that person is able to lose about 15, 20 pounds. They are stuck there, and then the weight comes back up again, but then they end up with a weight which is higher than when they started the diet and exercise program. And this goes on and on and on in a yo-yo fashion most of their adult life. And the reason this happens is because once the person diets and exercises and try to come down on their weight, the body almost adapts by decreasing its metabolism and therefore making it very, very hard for the person to lose any more weight. So there is an adjustment that the body undergoes to defend that particular weight, as I said before.
Now, when the body senses that you might be in a state where you're starving for food, that is, you're not really eating a lot of food, just burning your own body fat to survive, then the survival starvation mechanism kicks in. And what that does is that on every individual cell level in your body, it changes how you process energy. So it tries to conserve every little bit of energy it can. And in fact, it's been demonstrated that for every 10 pounds of weight loss, your body requires 100 less calories to survive. And that's a big difference. So if somebody has lost 100 pounds, there is a chance that they need 1,000 less calories to survive, and that's a big deal. 1,000 calories for some people is their entire day's energy supply. So because of the starvation mechanism, your appetite goes up. So you look for food, you hunt for food, it slows the metabolism down and you tend to regain the weight back. And that's the problem. So it's weight loss, weight gain, weight loss, weight gain. And most people, most patients, most webinar attendees who come to see us, they've gone through this weight loss, weight regain cycle over and over again. And each time realizing that the weight goes up a little more than what they were when they started out. What do medicines and surgery offer? Well, what they offer is a way out of it. So once you've lost the weight, and once all those increased appetite and metabolic changes occur, that's where weight loss surgery, or especially weight loss surgery and some medicines, can help curb your appetite, for example, or with the surgery especially, prevent you from being able to eat large portions of food, or not let you digest all the food that you're eating, and therefore bail you out of this cyclical weight loss, weight gain, weight loss, weight gain. And it's a way out, a successful way out for patients who are able to follow our instructions to a much healthier weight and a healthier life.
When we talk about the efficacy of surgery and we compare it to medications or diet and exercise, it's a huge difference. For example, if you go on medications, you might lose 10% of that excess weight. Like I have 100 pounds on me, I lose 10 or 11 pounds in the next 3 years on medications. While with a bypass or a sleeve surgery, you will lose anywhere between 70 some to 60 some, which is a big difference. And the same thing applies for diet and exercises. So we have a big problem and we have a big solution for it. It's a big decision, but it's the only effective decision.
To be able to have the surgery, you have to meet certain minimal criteria. The first thing we ask our patients to check is their body mass index. So you can go online, plug in the numbers and figure out what your body mass index is. So the most basic requirement is a body mass index of more than 40. So if your BMI or body mass index is more than 40, then for almost all insurance companies, you're considered a candidate for weight loss surgery, whether you have any other medical problems or not.
As I said, there are exceptions to this. Sometimes even a body mass index as low as 35 can make a person qualify for weight loss surgery if that person has already developed conditions like type 2 diabetes, high blood pressure, or sleep apnea that are related to obesity, in which case we say we don't have to wait for the person to gain more weight before we offer them this important treatment.
Obviously, we're an adult surgical practice, so the person must be 18 years or older. Some insurance issues, we get denials because the patients never tried a medically supervised weight loss attempt. They say, oh, I did Jenny Craig back in 1988, and well, we don't have any records, so they just, they write that off. You're not going to get surgery paid for that. And then honestly, you need to have the insight to be able to understand the surgery and its risks. We have patients who their insight into their disease process doesn't run that deep sometimes, or they have an inborn error of intellect or insight. Down syndrome patient, for example, I don't operate on Down syndrome patients because often their insight is moderately impaired. The patient must be an acceptable operative risk. That means that they can't be too sick for surgery, because the surgery is supposed to help, not hurt. And this is a significant operation under general anesthesia, and patients who are too sick can sometimes not make it through, whether it's a gallbladder, an appendix, or a hernia. Certainly bariatric surgery will be counterproductive as well. And then most importantly, they have to be ready to commit to these lifestyle changes that I mentioned, which means you need to be able to shop and understand what high protein, low carb is. You have to understand that these artificial sweeteners, although they're 0 calorie, are not chemically good for the body, and they do derange the metabolism, so they should be removed. And they really need to be able to say, you know what, I'm going to shop for good quality food and not just this ingestible stuff that I pick up at the Wawa or the gas station. That is really not edible food.
Now, there's mainly 3 surgeries done nowadays. Number 1 is sleeve gastrectomy, it's the most common, followed by gastric bypass, and the last one is what we call lab band. Now, it's very rarely done nowadays. It used to be popular 10 or 12 years ago, but not anymore. We'll come to that point, of course. Now, before I talk about the surgeries, I want to explain the principle by which these theories work. Now, we do believe the source of the problem is the stomach itself. I don't mean your entire belly area, I mean the stomach organ itself. It's the first organ that receives food. When we eat our food, we swallow it. Our food pipes or esophagus deliver the food down to the stomach. Now, when the stomach is empty, it's like a balloon, very small, but it can stretch and accumulate a large amount of food and drink in the same time. When you go out, you get a drink, you get an appetizer, you get your main course. All that food goes down to your stomach. And your stomach keep it for itself for like a couple of hours, smush it, mix it with acid, then start to push it down to your intestine to start the digestion and absorption of food. So the problem comes is we keep eating because our stomach allows us to eat more than what we really need. So the idea of any bariatric surgery is to prevent that from happening.
Now, why do patients choose this? Well, for a couple of reasons. I think one of the main reasons is that it is less complicated than the other surgeries. It's a quicker surgery. It's a much, I think it's a little quicker recovery sometimes. But also because I think, and I strongly believe this, is that it really helps control your hunger very well. And that's one of the biggest benefits of the sleep hysterectomy. Now, we do have a little video to help explain what's involved in the procedure. Here we go. It's a cartoon video. So, there we go. So, the surgery is done through small cuts on the belly wall. So we make several small cuts through which we're able to introduce these ports or cannulas through which we can then introduce our surgical instruments. So this is the food pipe, this is the stomach, and this is the intestine. The stomach is very stretchy. It can stretch to hold anywhere between 1 to about 1.5 liters of food at a time. Especially this part of the stomach, we call this the fundus, is very, very stretchy. So what we do in a sleep hysterectomy is that we remove about 85 to 90% of this stretchy portion of the stomach. So you end up with a really small stomach that's only about half a cup in size. That's about the shape and size of a small banana. So the way this surgery works is, first of all, you can't really eat a lot of food. All you can eat is about half a cup of food. And with that big portion of stomach removed from the body completely, you actually feel a lot less hungry. As it turns out, the stomach makes a chemical, a hormone that's called ghrelin. And that's related, that actually, when its levels are high, it makes you feel very hungry. And once we've removed a significant portion of the stomach, the levels of this chemical, they go down, and you feel much less hungry.
Our gastric bypass operation, we're also doing these as outpatients now. So come in the morning, home in the afternoon. We've done them at the Surgery Center. These take a little bit longer, maybe an hour and a half, but this involves a different plan of attack for the calories. What we do is perform both a restrictive and malabsorptive procedure when we do a gastric bypass. So again, it's done laparoscopically, typically 5 small incisions, get within the abdomen as we did before, move the liver out of the way. And then the stomach, when it's found, we leave it in place, but we decrease the size of the stomach by cutting across the upper portion, starting at this incisura right here. So coming across with a stapler and then coming up, we then create a small pouch. So you're going to fill full very quickly in this pouch. Obviously that food needs to get out of there and go downstream, and we'll actually go into the intestine and bring the intestine up to the pouch. So now the food goes directly into the intestine. Now the bile and the pancreas juices are coming downstream, and at this blind end, they'll be reconnected here so they join up with the food. So a very small amount of food is taken in, number one. And number two, you do not absorb all those calories until you mix with your bile and gastric secretions and the food is absorbed here. So about 5 feet on average of intestine where no calorie absorption occurs. Okay.
The third option is something we used to call gastric band or lap band, and it used to be very common and popular like 10 years ago or so. The reason is, very simple to do, very easy, no cutting of stomach or intestine. The idea was to implant a device around the stomach, up here. It's like a balloon, and you wrap it around the stomach. Then have a catheter, and the other end of the catheter, we implant beneath the skin. Then you come to the office, we feel the end of the catheter, we have a special needle that goes there, and we inject water. So the balloon gets bigger. When it gets bigger, it squishes your stomach. So the inside or the lumen of your stomach is tight or narrow. So what that does do, when you eat your food and it goes down to your food bite, it gets stuck here. Think of this like driving on a highway. Let us say nice day, sun is up, 3 or 4 lanes, not too many cars, so you can run quickly. Let us say down the road there's a crash or a repair. Now 2 lanes are out of commission and everyone has to squeeze in 1 lane. What happens? Traffic slows down, you get congested, now you have a traffic jam and things are not moving. That's exactly what happens. So when you eat your food, it goes down here, you get stuck. So after a couple of bites, you feel full, as if you ate a huge meal. Then it will break down and pass through to the digestion.
Complication rate is less than 1%. We are a center of excellence, which means that every year we have to report all our complications as well as our outcomes, and we're held to a certain standard. So when you lose weight rapidly, whether you're on a diet or whether you have weight loss surgery to help you lose weight, you could develop gallstones, and gallstones could cause you pain and gallbladder disease. If you don't take anything for it, that's about a 30% chance when you lose weight rapidly that you could have gallbladder problems. So we do give you medication to dissolve gallstones, and you're usually on that for 6 months after surgery, and that decreases that risk from like 20% down to 2%. Hernias can occur anytime you have an incision in your abdomen. You can also get them when you're overweight, so you can get them in things like your belly button and your groins. But hernias from surgery occur less than 1% because we use those small incisions. Malnutrition can happen after weight loss surgery, as well as vitamin deficiency, especially if you're not eating properly. So we do follow you for the rest of your life. We do labs at 6 months after surgery, 1 year after surgery, and annually thereafter. If you have any weird symptoms, then we'll actually do them more frequently to make sure you're not suffering from any malnutrition or any vitamin deficiency. When you're overweight, you're at high risk for blood clots to your legs and to your lungs, and that risk is about 1% with about a 1 out of 2,000 risk of death. Because of that, we do give everyone blood thinners 2 hours before surgery. And then we also get you up and walking right after surgery if we feel that you're high risk, so meaning you walk with a walker, you've got changes in your legs that look like you're at risk for blood clots, or if you've had a history of blood clots, we basically put you on blood thinners for a month after surgery. If you have a family history of blood clots, we'll actually have you see a hematologist to make sure that we are doing the right medication to prevent you from getting blood clots. Blood clots is actually the most common cause of death after weight loss surgery. It's infrequent, but it can happen, so we do all these things to try to prevent it from happening. Wound infection is rare. It's rare because we do it through those small incisions. Anytime you have any surgery in your abdomen, there's always a risk of blockage in your intestines sometime in the future. Because it's done laparoscopically, that risk is less than 1%.
Well, this is the same slide showing you the benefits of weight loss surgery, because not only is the person becoming a lot thinner and a lot comfortable with their own body, but they are also liberated from the many medical problems that are tied up with obesity. This includes things like heart disease, high blood pressure, heartburn or reflux, joint problems, stress urinary incontinence, infertility, type 2 diabetes, the metabolic syndrome, fatty liver disease, high cholesterol, and so forth. So this is one of the rare situations in medicine where one intervention can actually lead to improvement of many medical conditions.
For patients who come to see me and they don't actually meet criteria for bariatric surgery, we have, on top of medical management, we do have endoscopic balloon therapy, where a gastric balloon is placed in the abdomen, in the stomach. And this balloon actually just makes you feel full. It stays in place for 6 months, People can typically experience 25 to 35 pounds weight loss. Obviously, a good diet plan is mandatory. You do get follow-up visits for a year with the nutritionist, and after the balloon is removed in 6 months, it's those nutrition visits and keeping your appointments that will really, ingrain the ideals of good quality nutrition in your brain and maintain that weight loss.
So we send patients for heart workup, for lung workup, depending on one's risk factors. We send patients for sleep apnea evaluation, depending again on the risk factors. All patients have to go for psychological assessment to make sure that there is no underlying eating disorder or untreated mental health disorder that might need to be treated before surgery. We'll be ordering blood work, chest x-ray, and we also perform an endoscopy. That's a procedure where we go around the food pipe into the stomach, and we want to make sure that there is no disease that affects the food pipe of the stomach, something that might need to be treated before or at the time of surgery. And then once everything is done, then patients go back and see their primary care doctors, and they give us a final clearance letter. And that's when we schedule surgery. And then about 2 weeks before the surgery, sometimes in some circumstances 3 weeks, but for the most part 2 weeks before the surgery, patients are required to start this preoperative diet. It's called robot new direction. And the goal of this diet is to help shrink the liver. You see, the stomach actually lives under the liver, and in patients that have extra body weight, the liver can get very large. And staying on a diet such as this one, which is high protein, low calorie, the liver shrinks down and gives us better access in the stomach area. And so we can perform this surgery in a much more safer fashion. It is something that you have to plan for. It's something you have to buy from us. It costs a couple of $100. My office can give you more details about that, but certainly something that we ask our patients to prepare to kind of plan for, depending on the time of the surgery. And of course, since you might be interested in having weight loss surgery, I would highly recommend call your insurance companies to see if you're a candidate for weight loss surgery. Just confirm that you have those benefits. Most insurance companies cover this surgery now.
I'd like to invite everyone to please follow us on Facebook. We have more informational sessions like this. And if you have any additional questions, please email us at info@CHRIAS.com. You may also visit our website. We have some videos there and more information regarding the procedures that we do, as well as some other procedures that, information about our office. And please follow us on Facebook at facebook.com/CHRIAS.